Welcome to Health Bites. Thank you everyone for joining us this morning. It is my pleasure to introduce our guest speakers and my South Carolina colleagues, Dr. Vanessa Kitzie, Dom Francis, and Nick Vera. Dr. Kitzie is an assistant professor at the University of South Carolina School of Library and Information Science. Her research and teaching interests include human information behavior with a focus on information marginalization, gender and sexuality studies, and social justice and diversity in librarianship. Dom is a training coordinator for the Center for Community Health Alignment with the University of South Carolina's Arnold School of Public Health. As a training coordinator, Dom's primary role is to develop curricula and facilitate training for the center's anchor initiative, the CHW Institute. Nick Vera is a Ph.D. student in the School of Information Science at the University of South Carolina. Prior to starting his Ph.D., he worked in the Low Country region of South Carolina with the local nonprofit SC Thrive to provide innovative and collaborative tools to help underserved communities efficiently access quality of life resources. In today's Health Bites, Dr. Kitzie, Dom, and Nick will give a presentation on establishing partnerships between librarians and community health workers to promote LGBTQIA+ health. Thank you to Dr. Kitzie, Dom, and Nick for being our guest speakers this morning, and I'll turn it over to our speakers.
All right, I'm going to go ahead and kick us off. Again, my name is Vanessa Kitzie. I'm an assistant professor at the University of South Carolina School of Information Science. And I would just like to thank the South Central region for having us today, as well as the interpreters and the folks doing live captioning for us, and for you all for being here today. And then finally to Shannon for that wonderful introduction and also working with us on this project. Just a quick note on terminology. You will see that we tend to refer to the communities and people that we're talking about today as LGBTQIA+, but just for intelligibility reasons, and quite frankly, because it's easier to say, I'll be using queer and trans throughout this presentation to refer to our communities. That being said, identity labels are very complicated because while they're affirming, they also can fail to capture the fluidity and multiplicity of people's life experiences and how they want to identify. So if you have any questions about our terminological choices, please feel free to ask them. I'm happy to talk about them in more detail. Next slide, please. All right, before I get started, I'd also like to acknowledge that the work that we'll be discussing today is supported by 2 grants from the Institute for Museum and Library Services, or I'm sorry, Institute of. And so they're supported by an early career development grant as well as a national leadership grant. And there's some links there for more project information, which I'll put in the chat later. Next slide, please. And so we went over our team members, but this is not just comprised of us. There are other fantastic people working on this project. So I have a link at the bottom of the slide so you can see the full team. It includes the wonderful Shannon Jones. Slide, please. And so today, this is just showing you our agenda. We'll each speak for about 15 to 20 minutes on a different facet of our projects. And so I'm going to kick us off by talking about some of the research that we've been doing over the past 4 years with queer and trans communities and people throughout the state of South Carolina. And that work has really motivated and contextualized our current project, which Dom is going to talk to you about. After Dom discusses our current project, he'll then turn it over to Nick, who's going to talk a little bit about lessons that we've already learned about establishing partnerships between librarians and queer and trans people and communities. Next slide, please. So as I said before, I'm going to be discussing some prior research that's informing our current project. And this research has been conducted over the past 4 years. It consists of individual interviews with queer and trans community leaders from across the state of South Carolina. And these interviews have included topics like what communities' health questions and concerns are, as well as how they address these questions and concerns. We validated our interview findings with community leaders, with community members who participated in focus groups. And based on these findings, we conducted a community forum between library staff from across the state of South Carolina and community leaders to brainstorm how and when to establish effective partnerships. Now, I've been using the word community a lot, and you'll see it all throughout our presentation, but I just want to acknowledge community is a fraught concept. However, it's been found in the research to be very critical in shaping how queer and trans communities address their health questions and concerns. So that's why we're using it as a... Next slide, please. So I just want to provide you with a little bit of information and context about living in South Carolina and health outcomes among queer and trans people and communities within that state. So you'll see on the left-hand side a distribution from the Williams Institute that shows you across the 4 US regions, the proportion of people who are open about identifying as queer and trans. And one thing that might surprise some people, but maybe not others, is that the largest proportion of queer and trans people who are at least outwardly identifying as such are located in the South. And I think one of the reasons why that might be surprising to people is because we've often been fed this narrative that if you're a queer or trans person living in the South, you can't live a meaningful life. And so I want to just push back against that sort of assumption, and also the assumption that queer and trans people often flee to coastal urban hubs, because not everyone has the resources to do so, nor do they have the desire. That being said, it does not discount that geography is certainly a key factor that shapes health challenges experienced by queer and trans people within the state due to a unique legal and material patchwork that shapes how resources are distributed. I've given you some bullet points that just go over some of these challenges, but what I want to do is talk a little bit about the role of information in all of this. And specifically, we've found that information a very large role in contributing to the health inequities experienced by queer and trans people in the state. I'll just give you one example, which I think we could generalize to the US, lack of information and certainly affirming information on sex ed and reproductive health that is taught to queer and trans people. Now, why this is notable is that up until last year, South Carolina was one of 6 states that had what's called a no promo homo law on the books. And essentially what this law did was it forbid public school educators to even discuss queer and trans identities and issues within health classes. So this is an example of information that is being withheld from queer and trans people and communities. And these challenges can produce health disparities. And so I'm going to read you now a quote that gives you an example of the health disparity from one of our research participants, Vera. And just to note, I'm using pseudonyms or fake names to refer to all participants because I'm going to read you a couple of quotes throughout my duration of the presentation. And I also include all quotes on the slides. And so here's what Vera says. And Vera here is talking about the lack of affirming sex education that's offered within schools in the state of South Carolina. And I mean, that's why you see in the LGBTQ community, especially amongst the youth, there's actually a lot of teenage pregnancy. And it's because they have no accurate sex health education. And they think that if enough sex with somebody of the opposite sex, that it can fix their problem because they're not taught anything else. Next slide, please. So our research is really about kind of identifying what information inequities people experience, like being withheld information. Once we understand what those inequities are, we're also really interested in what communities are doing despite experiencing these inequities. So in other words, how do they create, seek, share, and use health information in order to promote their health and the health of their communities? And then a final area of interest within our research projects looks at how library staff. So we've looked at public library staff, and now we're starting to explore this from the context of medical libraries. How can library staff and queer and trans communities collaborate for health promotion? And so now what I'm going to do is just briefly go over what we found related to items 1 and 2 that are listed on this slide. Next slide, please. So what we found is that we can divide the information inequities that are experienced by queer and trans communities into 5 different categories or levels of analyses: intrapersonal, interpersonal, organizational, community, and public policy. And these categories are informed by existing public health models. Next slide, please. So what I'd like to do now is just illustrate through 2 examples from participants how these information inequities are experienced at 2 different levels of that model that I just showed you. And so you see on this a quote from participant Pat. And in this quote, Pat demonstrates an information inequity at the public policy level when discussing how pharmaceutical companies and healthcare systems shape what health information needs certain queer and trans communities should have, and the types of health information and resources that are available to them. And so here's what Pat had to say. So one of the things that frustrates me to no end is the way that HIV/AIDS is kind of weaponized against Black trans people. And so we are really the face of what HIV is to a lot of people. Have you ever heard of the broken windows policing approach, where instead of responding to crime, I'm going to find the crime? A lot of times that's what it's like with the Black queer community in terms of HIV and STI testing. And so what Pat's narrative tells us is a key finding of our research, which is that while access to health information and resources is really important, this access doesn't solve information inequities. HIV and STI testing, information, and resources are accessible to Pat and her community. But because these information and resources are so accessible and so visible, they can limit other health information that might be of importance to this community. And they could also advance a harmful narrative that Black, queer, and trans people always had STIs and HIV. Next slide, please. So here's another example of an information inequity experience intrapersonal level. Annalisa describes her community using the internet for, quote, just doing research on your own to try to make sure you're getting the correct standard of care, because maybe you don't know and you think the doctor's doing things correctly, but maybe they're not addressing something. And so what Annalisa is describing here is an interpersonal information inequity, which is a lack of knowledge related to what a proper standard of care or should be for queer and trans communities. And through this narrative, she illustrates another key finding driving our research, which is that queer and trans communities engage with health information despite experiencing inequities at all levels of analysis. Since Annalisa and her community might not know what their correct standards of care are, and this is not through any fault of their own, but rather produced by a lack of cultural humility on the part of medical professionals, what her and her community do in spite of that is they do research on their own to determine what these standards should look like. Next slide, please. And so I'll conclude my remaining 5 minutes by just talking briefly about our second research focus, which is about how queer and trans communities create, seek, use, and share health information despite these information inequities they're experiencing. And so one way that they do this is by creating health information to educate others. And so this is illustrated by the quote from Shateria Cox on the slide. And so she says, there's a lot of websites run by our community that have information or values that may teach or help others learn about our healthcare. And so she makes a really good point here, which is that we often tend to frame people, particularly those from marginalized groups, as needing information and resources that only us as experts can provide. But what this quote allows us to ask is what happens when we invert this perception and instead look at what the experts don't know or refuse to know. Next slide, please. All right, so this is the final example that I'm sharing, and this is showing you how queer and trans communities also share health information in the form of personal experiences with each other. Kyle describes how this word of mouth operates in his community as people say things like, hey, I went to this and they actually knew about gay people, or like, hey, they actually knew about trans people, so maybe we should go to this doctor. And then everybody flocks there. And so what Kyle shows us in this example is how the health information practices of queer and trans people are often used to defend against a perceived negative outcome, such as visiting a doctor who doesn't know about trans people and being dead named and misgendered as a result. Next slide, please. I lied to you. I have one last example. And this example is showing you how communities engage in collective information seeking. And so here, Ben describes how he and his friends meet after school. We get all of our questions, like who's going to the doctor's appointment? And so we go to the doctor's appointment and ask 5 questions. So in other words, Ben gathers with his community after school, they collect their questions, and the next person who has a doctor's appointment asks those questions of their doctor. And I think on its face, this activity might seem unsafe. Shouldn't you, if you're having a health problem, go to your own doctor? But in reality, this practice is a way for these teens to access information and resources that are inaccessible to those who aren't out to their doctors or families or can't afford to or be transported to the doctor. And so just some key findings from this research before I go ahead and turn it over to Dom. Communities aren't lacking or less than. They're not problems to be fixed. And viewing them this way minimizes their lived experiences, which tell us the reality that queer and trans people and communities are acting despite the challenges that they experience to connect others within their communities with health information and resources. And so based on this key finding that queer and trans people and communities are already doing the work to address the information inequities they're experiencing, we started a new project, which is currently underway. And this project formally equips queer and trans people from South Carolina with the training and certification to continue the work they're already doing in the capacity of serving as a community health worker. And during this project, we'll also be partnering them with health sciences librarians who have a history of supporting frontline public health workers like community health workers. During this partnership, they'll be building an informational resource for each queer person's community. And so now I'm turning it over to Dom, who will describe our current project in more detail.
Awesome. Thank you so much for pitching it to me. Great start, hard act to follow, but I'm going to try to anyway. So as Vanessa said, I'm going to take over from here and talk a little bit about the research training in partnerships, more specifically involved as Vanessa gave a lot of that background and bird's eye view. And so can I get you to click the next slide? And we're actually going to move past this slide as well, because that's what I just said. I should have said that before, but it's okay. So giving you the why of our project as if it weren't already kind of screaming at you based on what Vanessa had said, there are a number of needs and there's a lot of significance to it. And so in speaking about those needs, the overhanging theme there is the removal of informational barriers that cause health disparities. So that's going to include, difficulty accessing relevant health information, assessing the safety of that information, creating resources once that information is collected, and being able to disseminate that information and those resources to the community. And then as far as significance goes, again, overarching theme I like to give is the parallel between key intermediaries in CHWs. There are so many practice-based opportunities as it relates to addressing a national need to increase the number of CHWs, extending service to underserved populations, the limited documentation of CHWs explicitly serving queer and trans communities despite significant health challenges they face, the opportunity to create those informational resources for the communities, and then the medical librarians being known, as Vanessa had said, being known to work with public health workers, but there's less evidence in practice-based research around CHWs, specifically working with medical librarians. And so we want to be able to facilitate some of those partnerships. And so could you go to the next slide? Talked about some of those practice-based opportunities, and now to talk about some of those research-based opportunities. There's this big opportunity to observe the characteristics, the facilitators, and the barriers of such partnerships, advancing the conceptual model describing queer and trans health information practices, and adding to that literature in a very intentional way. The project contributes to the LIS and public health fields by advancing that model. And there are some practices that Dr. Kitzie has developed earlier in her career that we've sort of alluded to, that just adds to the scant literature, kind of just giving you an overview again of what you see there on the slide. I'm moving kind of fast, but I anticipate that there may be some questions as we get a little more into the logistics of the project overview, which is on the next slide. If you could click for me, please. Training trans and queer people as CHWs, including specialized curricula about trans and queer health, is something that is just super exciting and cutting edge, even, if you will. And so in talking about that, what I'll specifically say is that we plan to provide folks with the support from medical librarians during their core training, as well as having folks leave with an information resource created for their community. So, we're not just going to have this one-off training and they go out into the world. We want folks to come away with things that they can use, tools at their disposal in combination with that CHW professional development that we want to give them. And obviously the project's also going to give us the opportunity to collect data about the unique experiences of queer and trans folks who are serving in a CHW role, and all of the intricacies, or not all of them, but some of the intricacies that come with being queer or trans, a CHW, and what the process looks like creating, seeking, using, and sharing that health information in their work. Next slide. And so I kind of alluded to it earlier, kind of 3 parts to think about this project in: the training, the partnerships, and the research. The project started in spring of this year and will go to spring of 2022. So next year, there will be approximately 210 hours worth of engagement. The majority of that is community health worker training. And this is where you're about to really see me get excited, because all things CHW training, I'm excited for. I love the concept of involving folks in the strengths that they bring from their communities and being able to serve their communities. Something Vanessa said that is super important and often reiterated in the community health worker space is that individuals or communities are not entities to be fixed. They are individuals to be engaged with and communities to be engaged with. And they have strengths that we can help them capitalize on, we can help ourselves capitalize on in order to be able to address barriers and challenges that we have. So I just went on my little soapbox there for a second, but the last note I'll make on this slide is that the training is going to occur from fall to winter, but we're going to go into more detail about that. Can we go to the next slide, please? And so something you probably noted is that my job title has a very long acronym in there. And so I'm the training coordinator for the Center for Community Health Alignment, which is part of the Arnold School of Public Health at the University of South Carolina. And if that's not a mouthful of words enough, our core initiative and the one that we're talking about in this specific context is the Community Health Worker Institute. So whole list of acronyms, but for the purposes of this presentation, you see the CHWs at the bottom, the Center for Community Health Alignment. You might hear me say CHWs, that's just how I say it for short. But our core initiative is the Community Health Worker Institute, and that's where the training of our folks that we have participating in this project comes in. And so in summer of 2021, what we plan to do is have 4 hours of curriculum and sample unit theater testing. And then in the fall, leading into the winter, we're going to have those 80 hours of core competency training, 80 hours of field work, and 30 hours of specialized training. And just to give you a little more detail there, what's going on is 80 hours of core competency training. That's what it's called, CHW core competency training. And what that is instead of having a very knowledge-based or information-heavy training, we want to focus on the skills that we want training participants to develop. It's less about head knowledge that folks might have about a certain disease, condition, or treatment, and more about navigating resources, connecting people to those resources, and characteristics and qualities of the like. And then there's 80 hours of field work, so what we call practicum sometimes, that is same nature of content that we want folks to receive, but the way we go about delivering it is very different in that you might assume field work is going to be more hands-on stuff, more going through some of these motions and practicing what it's like to be a CHW. And then last, those 30 hours of specialized training content that's going to relate to specifically queer and trans folks and how looking at things through the lens of that demographic may impact the work that they do and the information that they have on hand. Next slide. And so here we sort of alluded to it, but just wanted to give you some more specifics on that schedule. We said fall to winter. So you see September 2021, we're meeting for 3 hours a day for the weekdays. So we're going from 9 to 12. And then the last 2 weeks, so that's the first 2 weeks of training. And then you come to second 2 weeks in September sorry, I'm describing this terribly and I need to be less distracted by the visual and just do more what I know how to go by. You have your first 2 weeks of training, 3 hours for 2 weeks for weekdays, and that's going to account for 30 hours of the training. And from those 30 facilitated hours, that's part of that 80 that I mentioned earlier being core competency training. Then they go into their field placement for 80 hours now that they have 30 hours of in-class and theory learning, so to speak, and then they'll demonstrate and learn some more about those. And that's going to happen September through November. And then in November, they'll get the last 50 of those 80 core competency training hours to really bring everything together, what they applied in practicum, those sorts of things. And then they'll sit for the certification exam, which is actually administered by the South Carolina Community Health Worker Association. We affectionately call it CHWA because we try to abbreviate as many of these acronyms as possible. That's a 2-hour exam, or 2 hours is allotted. It typically doesn't take folks that long. And after going through 160 hours of training, it'll actually seem like far less of a threat than most things. And then the specialty hours happen here in December for 3 hours a day for 10 days. I actually have a question, and I want to address that. Someone asked, would the 30 hours of specialized training be available as a standalone certified CEU for current CHWs? And my response to that is, that's the hope. And just to, I don't want to go on too much of a tangent because I want to kick it over to Nick here really soon. Currently in the state of South Carolina, the South Carolina Credentialing Council for Community Health Workers does not have an established CEU process yet. But I do know just from my inner workings and my network that they are working on that, and they hope to have that by the time we're ready to give this certification, and so that, or to give this specialized class. And so the hope is that by the time we have, by the time we're allowed to implement this, there will be a CEU process, and we can make sure that our specialization training is up to par and we can offer it as a CEU for CHWs. So great question. Thank you for asking that. How will you recruit CHWs into the program, and will they be paid for going through the training? I appreciate you asking that as well. And I want to give an opportunity for Vanessa or Nick to speak to that more. And so I'm going to pause and first say, I think they may talk about that a little bit more, but if not, one of y'all, if you want to jump in.
Yeah, I could jump in, and this is a great question. So we have actually already recruited 13 CHWs to participate in this program. We did recruitment a little bit differently than our initial stage of research, which was, going into different communities and talking to folks and being like, what are you doing and what challenges are you experiencing? So we talked to folks when we were doing that research, ages 13 and up, mostly because there are some really great youth activists, queer and trans organizations and work going on. And so we wanted to get their perspectives. For this part of the project, we did have to limit the training to 18 and over. So we're recruiting adults. We did recruiting in a couple of different ways. We did it based on prior contacts established in the first phase of the research. And so that really came from being embedded within some of these communities for myself personally, and then also from getting through snowball sampling recommendations of other people who we should be reaching out to or talking with. And so we already had a base of folks that we can go to and say, hey, based on what we've learned from you, these are the next steps that we want to take. We want to be able to get you the training and credentialing to support what it is that you're already doing. Would you be interested in participating, or do you know of others who might be? The other thing that we did is we developed a list of over 100 queer and trans visible organizations and communities within the state. So we know that there are hidden ones, but these were the visible ones that we were able to find. And we also have affinity organizations. So think like Black Lives Matter chapters, UU churches. We reached out to those organizations as well and said, hey, do you have anyone who might be interested in participating in this project? So that's how we recruited. After that, what we did was we had folks attend an interest, because as you can see, this project has tons of moving parts. And so we wanted people to understand that this wasn't just kind of a one and done research project. It was more of a sustained project, including training elements and partnership elements. We then had people who were still interested fill in a questionnaire, which came from the Center for Community Health Alignment. And this questionnaire is to assess the various characteristics and skills that folks can bring to the table and determine whether that aligned well with community health workers. So one example would be, if you have someone who really wants to do this training, but they're not trusted within their community, that's not going to be someone that you want to have on board. We also are fortunate in that we have some fantastic folks on our advisory board who are embedded within queer and trans communities. And so we were also able to vet folks to make sure that we weren't identifying people who could be harmful within these communities. And so that is how we, and then we're able to get this cohort of 13 folks. In terms of will they be paid for going through the training? Yes, they will. So we calculated that it's about 210 hours of training, research, and partnerships work. We assess that at $25 an hour, and so we're paying them stipends of
These right here are journals, those two are books. The magazines go in the
we assess that at $5,250. So they're all getting a stipend of that amount. And the other cool thing about this is that being a community health worker, you can do it on a voluntary basis, but you can also have it as a career. And so one of the things that we'll be doing in partnership with the Center for Community Health Alignment is offering folks the opportunities to try to pursue this as a career. We're having a community forum at the end of this project with healthcare professionals from across the state. So that's a way for folks to be able to network and perhaps pursue job placements if they're interested. So I will shut up now and turn it.
Oh, you are fine, Vanessa. I appreciate that you stepped in there for me, because I wanted to make sure we got all of those sort of intricacies in the question answered right. And it's just exciting to hand it off to teammates and watch folks go. So if you want to move to the next slide, that would actually be great. So research, just very briefly to give some insight on that. We've talked about, what data and information are we collected. And so just to give you an overview of the methodology there, in the spring, there were 1 to 1.5 hour individual interviews conducted with these folks, as well as in fall to winter, they will have 4 20 to 40 minute audio diaries that they will use to sort of record their experience, challenges, and observations that they've noticed. And then in spring of 2022, each person will have the opportunity to be a part of a 4-hour community forum, as well as a 1.5 to 2 hour focus group to communicate about their experiences. And that's overall before, during, and after the community health worker training, so we can really see what the impact was there. Next slide, please. As far as research goes, research continued, types of data collected and analyzed. We've kind of already alluded to this, but your basic demographic information, those audio recordings from interviews and focus groups, observational notes, brainstorming notes and drawings. It's really qualitative heavy, right? There's so much opportunity we're trying to take advantage of as far as seeing, what folks really think, as long as they're willing to share. And also photos of the community forum, blurred out faces, just as an option in case folks want to maintain a little more privacy there. And so just so you have an idea of how that information will be used, we want to have some publications and presentations, transcript only, no audio. And so that'd be including, but not limited to, your journal articles, book chapters, white papers, things of that nature. And so I'm going to bring it on home with the last slide. If you could click next for me. Partnerships. We already talked about it a good bit. Having a medical librarian who can assist that community health worker with the health information needs that they might have during training, and help the CHW create that informational resource for the community. We're super excited to see that synergy. really manifest itself in this partnership. And so in summer of 2021, there will be one to 1.5 hour initial brainstorming meeting. And the researchers will really be observing the meeting during that point. And then in the fall winter phase of the training, there will be 1 to 1.5 hour meetings during the CHW training, and the researchers will have the option to observe one of those. And again, really just trying to maximize, the strengths of folks in various professions. I see that we got another question, and sorry, I just got back to it, but I figured I'd pull us through the rest of this, and then we can elaborate on the end. And Nick, I'm so sorry that I was all over your time there. Someone again wanted to ask one more question. Are CHWs reimbursed for services by insurers? That's a loaded question. And in short, depends on where you are and what the community health worker is labeled as. Right now, that's currently a huge battle in terms of financial sustainability for the community health worker workforce, because depending on what organization a CHW works for, what setting they're in, because CHWs work in community-based organization, they work in MCOs, they work in federally qualified health centers, you name it. And what happens is there are a lot of different titles and duties that they attend to. So they might be a peer support specialist, or they might be a peer navigator, or they might be a promotora, just crossing a number of things. But in that, depending on what organization the CHW works for, there have been folks who have gotten creative and said, well, I have a CHW, they have this title, and we can get reimbursed for them completing these services. But it's not an across the board thing, which naturally, because also CHWs don't necessarily function exactly the same across the board. And in South Carolina, that's not a very prevalent thing. I'm pretty sure there are other states, and I wish I knew more about that. We have a side of the Center for Community Health Alignment House that really digs a little deeper in that. And I don't know if even informally, Vanessa and Nick have seen more research on that, but the long and short answer is it depends, but is it possible? Yes. And we actually hope that as we move forward, more services will be reimbursed by insurers for community health workers, because it has been known to substantially help organizations' bottom lines, especially healthcare organizations. And actually, if you go to communityhealthalignment.org, we have a lot of resources, one-pagers, links to other sites that talk about that even more. So I'll leave it there. And on that note, I will ask if you could go to the next slide, and I will pass it on to Nick.
Thanks, Tom. A lot of questions, it sounds like, which is good. So now I want to shift gears and kind of just talk about working with LGBTQIA plus communities for health promotion, and just some lessons we've learned along the way, as well as some ideas. Next slide, please. And so some of the lessons we learned or implications for how librarians can collaborate with queer and trans communities for health promotion are, one way is to shift from outreach to engagement. So as our findings show from community forums with community leaders, access alone is not a good remedy for information inequities experienced by queer and trans communities. And this is what outreach is about, access. So by providing resources to communities. And while this is a good start, it's not the end all be all. Rather, librarians should consider engagement models in which they partner with communities and let the communities kind of dictate how librarians can leverage their expertise to promote community health. So just to give you an example of what this kind of looked like at our community forum between public library staff and queer and trans community leaders is one thing many queer and trans leaders said they wanted library staff help with was creating and maintaining a list of medical professionals to go to. So librarians engaged in outreach would recognize this need and then independently develop a list. So those using engagement would partner with communities to get a sense of what specific values they use to assess medical professionals. So things like trustworthiness, safety, and affirmation of queer and trans identities all matter to LGBTQIA plus members and communities. So another example of collaboration here that came up from the forum was the idea that queer and trans communities could work with librarians and medical professionals to develop community competency trainings. And so these trainings could be both for medical professionals and librarians and held within library spaces. Next slide, please. And so another lesson learned here is how to leverage what communities are already doing rather than assuming they are lacking something. So I know that's been a theme throughout our presentation about what they're doing right. And so we view the role of public library here, the view of the public library here as a bridge that connects queer and trans people to one another and to the library and its resources and larger infrastructures. So we witnessed this in action during our community forum between public library staff and queer and trans community leaders. So for instance, leaders had a chance to use the library meeting room for networking without librarians or researchers present, which led to sustainable collaborations between communities that hadn't met before. So we also saw these connections happening when public library staff thought about how they might leverage what they already do to facilitate the community health practices. So an example here was a conversation between a public library staff member who was a notary and a trans community leader who helps other trans people obtain legal name changes. So the staff member and leader discussed a potential partnership where the leader could refer his community members to the librarian, who would then help them with the name change paperwork and notarize it. So this forum in turn acted as a catalyst for strong ties to form between community leaders and librarians. Next slide, please. And so our final lesson learned from our forums is an example that we think is worth sharing, which concerns our need as researchers and practitioners to understand queer and trans health information in context. So during our forum, we had a librarian say something to the effect of, quote, "I don't care if you are queer and trans. I'll treat your health information needs like any other person," to which our community leaders pushed back on. One leader stated, quote, "I need you to care because as a trans man, I have unique health issues that you need to be aware of in order to help me." So one aspect of understanding queer and trans health information in context is to recognize that when a person shares their queer and trans identities with you, you should consider how these identities may inform what types of health information are relevant to them. So another important point here is to recognize that if a queer or trans person approaches you for health information, the information you provide and how affirming you are of queer and trans people and issues is likely to be shared within and among community members. Therefore, what you're doing reverberates throughout queer and trans communities in a way that you might not even be aware of. So finally, it's also critical to understand that queer and trans people aren't monoliths. So as demonstrated by the quotes I've been reading to you, different communities with varying intersecting experiences of social difference will create, seek, and share health information in a variety of ways. And for this reason, it's vital to get a sense of the important identities other than queer and trans, informing people's engagements with health information. Next slide, please. And so, bearing all of these lessons in mind, I now kind of want to move to where we are currently at in this project. I know we've been taking you all around, but as of today, we're in the process of finalizing our health science librarian mentors to partner with our community health workers. And so far, the turnout and representation has been great by health librarians. So this past month, we have hosted virtual interest meetings via Zoom for librarians to learn more about the project and meet the team, as well as the timeline and level of commitment and just what we're asking of them broadly. So these meetings were also opportunities for librarians to ask questions and get answers before indicating their interest. So in total, we had 3 virtual meetings which were attended by 36 librarians from across the country and during the Medical Library Association annual conference nonetheless. So as we can see in this chart on the slide, we have folks attending from across the country and representing different regional chapters of MLA, with the highest attendance coming from the Midwest, Southern, Pacific, those specific regional chapters, which tells us that we're on the right track and that there is a strong interest among health librarians to serve on this project. So if you all want to ask any questions towards the end, I'm happy to answer any more details about how we've been doing that. And so finally, from these meetings we've been having, out of the 36 librarians that attended the meeting, we have about 15 that have indicated that they're willing to serve and be partnered with a CHW. And right now we're just trying to figure out what that pairing looks like, and bearing in mind just certain qualities of the CHW as well as the librarian and availability and that sort of stuff. And so again, like, here's our website. I know we've been posting that in the chat as well. So these are just some of the broader findings and implications that we've seen so far, and we're happy to talk about them in more detail and share more ideas during the Q&A. So thank you all so much for attending today's webinar and for giving us the time to speak.
Thank you again for that wonderful presentation. We'll now like to open it up for any questions. So if you have any questions, just please use the chat box. Please use the chat box to ask your questions.
Did you want to take that one, Vanessa?
Sure. So are the MLA CHWs meetings still ongoing? So we have actually done our final interest meeting. But Michelle, if you're interested in this project, please go ahead and send me now, because we have a recording of the interest meeting presentation. We are trying to, by next week, assign and lock in those partnerships. So there is still time to sign up if you're interested. Just repasted my email address into the chat for you. And so Cecilia, I just see you asked a question. What experience or feedback do you have from the CHW, as they mentioned or not mentioned, their work and interactions or lack thereof with local and state public health departments? So this is interesting, Cecilia, because we've learned about this a little bit when we've done this background research, and now we're learning about it again as we're interviewing the CHWs in training that we've recruited for this project. One of the things that we've asked folks to do across both projects is a visual mapping exercise called Information Worlds Mapping, where we give them a piece of paper and we say, put yourself and your community on this piece of paper. Around it, the people, places, and things that somehow influence how you and your communities address health questions and concerns. So it could be, sources that they want to avoid. It could be sources that they go to. It could be even sources that are relevant to them. And so something that we found when analyzing those maps is that unless then half of those drawings do we see local and state public health departments, and also things like hospitals or I'm sorry, I shouldn't say hospitals, or doctors' offices or things like that. Instead, what we tend to see sadly a lot is just a drawing of the ER. And folks will just say, like, I don't really tend to want to go to see a doctor or interact with a public health department until I have an issue where, like, I can't say no anymore, like I have to go in. What we do also see on maps is a lot of local health clinics and like pop-ups. So for example, like if you see pop-up testing at Pride or different Pride events, that would be a place that folks go to for health information. Also, like events and community spaces, so like bars and clubs are another thing that we see a lot, as well as social media, as you can imagine. So we see an absence in terms of interactions with local and state public health departments that are depicted on maps, as well as an absence of libraries. They are also not included. In fact, the one time that a library was included on a map was actually in a participant's aspiration drawing of what their ideal health information world would look like. And so ideally, they would like a library to archive queer history and queer stories, but they don't necessarily feel like that is the current reality. And thank you for that question.
I think we will stop the questions for now. Would you all mind just, if anyone asks any questions, that you could just respond to them in the chat? That way we can make sure we cover the demographics for today. But I would like to say thank you again for that wonderful presentation. And it was a pleasure to have you all with us. I'm going to stop the recording and we will cover the